Great, Matthijs, and organizers, thank you so much for this kind invitation. It's an honor to be a part of this really special group. And Matthijs, the way you asked the question there made it seem like I was going to tell this group what valuable metrics are going to be there. I'm actually going to flip it the other way. I need you to tell me what the valuable metrics are. So this will be this bi-directional flow of information that I think is really essential if we're going to move this forward. So thank you for the kind invitation. One of the things that comes up very frequently when we talk about the clinical application of ECGI is really what drives that clinical application? What makes something want to be used by physicians or patients? And you know, there's a list of things here, and I show really one of the most remarkable clinical/market adoptions, which is mobile cell phones. In 2005, the penetration of mobile phones was quite low. In 2016, more than 4 out of 5 people in the Western world had a mobile phone because it met all of these things. It was reliable, it was easy to use, it allowed communication. It actually created a new need. People were more connected and felt the need to be more connected. And you know, we should take these same concepts as we think about how to apply clinically the lessons that we learn from electrocardiographic imaging. I got involved in about 10 years ago with Yoram Rudy's lab. And on the left is our publication in Science Translational Medicine, where we took ECGI and applied it to the first group of patients with sustained ventricular tachycardia. And at that point, I think we were meeting needs and potentially creating new needs. But here we are 10 years later, continuing to refine what those needs are in the use of this. I want to show on the right, let's not just focus on the heart. So on the right is last year's introduction of electromyometrial imaging, taking inverse cardiology properties and turning it into inverse uterine properties. So we are non-invasively looking at a uterine contraction in a pregnant, in this case, a pregnant sheep. So we can apply these same tools to other diseases in the body as well, and other physiologic concerns. So how does inverse cardiology actually add to clinical value? And I think we can lump it, for me, I can lump it into the diagnosis, prognosis, directing the type and location of therapy. So from a diagnostic standpoint, you know, much of what we do with making the diagnosis of arrhythmias is done with a standard 12-lead ECG, the technology that's been around for 150 plus years. But I do think that there's opportunities to define new diagnostic diseases or tests using inverse cardiology, and some of them are shown here. Of course, I think it's very important to think about different ways that we can improve the prognosis for our patients, ways that we can phenotype sudden cardiac arrest risk, atrial fibrillation, and evaluate therapy for response. And once you can phenotype, then you can really tailor your therapy better. This to me seems like a very ripe clinical use for inverse cardiology and electrocardiographic imaging. Now, I spend about half my time in the EP lab trying to deliver therapy to specific locations of the heart. So I'm actually going to talk about the clinical use in the EP lab, primarily as pre-procedural or intra-procedural mapping to direct ablation of atrial fibrillation or ventricular tachycardia. So here we have this new tool of ECGI, and what are we expecting from it? Well, we're expecting it to solve our hardest problems, our most difficult and challenging problems. And I would say that right now that's persistent atrial fibrillation. So really trying to understand, and we've had a number of conversations already about being very careful about comparing the observations that you see, rotation, with the causative mechanisms of arrhythmia, persistence of atrial fibrillation. And so trying to understand these mechanisms is going to be super important. And I think this is a very valuable point of ECGI. One of the hardest parts about this is the lack of a true gold standard with invasive mapping to be able to help us understand that methodology and that physiology. So we can take pictures, we can interpret the maps, we can see patterns, whether they repeat or not, and we still struggle with the ability to compare the images that we have with the actual physiology that's ongoing. Moreover, with atrial fibrillation, it's not just a snapshot in time, right? This is a disease that can be progressive and oftentimes has multiple factors that add to reinduction of atrial fibrillation, reinitiation of atrial fibrillation, many of which fall outside of the current mapping time, whether it's with catheters or non-invasively. And so a number of risk factors, clinical risk factors that may further change the way atrial fibrillation affects a patient are in play. So this is a really challenging problem. And because it's difficult, I'm simply not going to talk about it right now. I'm going to move to a different problem that I think is equally important in the EP lab, but allows us the chance to make some important observations with catheters and then ultimately with photons. And so this is a map of ventricular tachycardia. And I think the expectation from ECGI in the EP lab is a big sign that says, ablate here, put your catheter in this spot and ablate. And if we look closely, we can see that there's a central corridor, there's an exit site that moves out and around, and this is a figure of 8 that moves back into that central corridor here. So we've got an exit, we've got an entrance, and we've got an isthmus. And what we really want is we want ECGI to be able to use all of the advanced metrics to define where is that isthmus for me to ablate. Now, we all know that ECGI is far more suited to see the exit site, not the isthmus site. So this becomes a really important thing for us to think through in terms of future developments of metrics that could be helpful or useful. We've talked a little bit about resolution, right? What kind of resolution do we need? What is enough resolution? We know that ECGI can determine very consistently the chamber of origin, left ventricle, right ventricle, and I would argue even the septum. And we're starting to see data, as Qingwo showed, it's showing the correct segment of origin if we think about this in a 17-segment model. And in our experience in the ventricle, ECGI is almost rarely wrong. And it's never very wrong. If it's wrong, it's just slightly off from a segment of origin standpoint. If ECGI suggested segment 5 and our catheter ablated in 6, we were fairly close. We looked at our first 60 patients that we used CardioInsight for non-invasive mapping at the time of a PDC or VT ablation, and that data is collected here and shown. And the accuracy is quite high in the left ventricle and in the right ventricle. And when it was not exactly accurate, it was a structure that was immediately next to it. So it can be very helpful in terms of identifying these ahead of time, but is that enough value to me as a clinician to want to learn this technique and implement this technique every time? Because what I hear time and time again is even if ECGI gets me close to the site of origin, I still have to go in with a catheter and map that and deliver the ablation through the catheter. And so does non-invasive mapping provide me enough data when I still need to use catheters? So I'm going to finish with 2 clinical cases that really highlight to me value with non-invasive mapping. And I think to highlight that, I have to at least explain what I do on my day job in the clinical cath lab. So when we do invasive ablation, it oftentimes takes up to an hour to get the patient sedated. Oftentimes we use general anesthesia for this type of a procedure. We put 3 or 4 or 5 IVs into the femoral vein or femoral artery. And once that patient is asleep, we have access to the heart. We maneuver the catheter around and make a very detailed scar map. And so here's an example. You can see all the different white points of the catheter, taking point by point, and then color coding the size, the amplitude of those signals, such that red is what we would consider scar or smaller amplitudes, and purple is the larger amplitudes, things that we would consider healthy. And it generally takes our lab about 30 minutes to make one of these detailed scar maps with a catheter. Then we induce VT, so we do the pacing maneuver, and here you can see VT starting on the top surface here, and this is the blood pressure line, and you can see when the patient goes into VT, the invasive blood pressure essentially falls. And so when we induce VT, roughly half of our patients, we have a very difficult time maintaining blood pressure, and it doesn't allow us to very carefully map in VT. But if it is hemodynamically tolerated, we'll maneuver that catheter around and make a very detailed activation map. And that could take 30 minutes or more in sustained ventricular tachycardia. Ideally, we're looking for this diastolic isthmus inside and around the scar, whether the scar is on the inside of the heart or the outside of the heart. We typically do some pacing maneuvers to confirm that that's indeed an isthmus that is participating in the tachycardia. And then ultimately we will turn on the radiofrequency ablation, initiate thermal ablation, and we oftentimes get an immediate, though somewhat shallow effect with this. And when we add all of this up and when we do that, we're very happy, but then we have to retest for more circuits. And so we repeat this process, which is well over an hour for each one of these VTs, and we'll get a second VT and a third VT. And so the procedure time for a patient ranges anywhere from 4 to 7 hours. And it's a very vulnerable time. The patient is asleep, general anesthesia, oftentimes in sustained ventricular tachycardia, and they're already pretty sick to begin with reduced ejection fraction. So not the right people that we want to leave in sustained ventricular tachycardia very long. So this is a case that I did recently where we had a 54-year-old gentleman who had an ischemic cardiomyopathy. His VT was refractory to medicines, and he had a large apical aneurysm on his CT scan. When we did the CardioInsight image in sinus rhythm, this is the voltage map, the unipolar voltage map. We can see a large area, in this case of red, that corresponded very closely to the apical aneurysm on this patient. And we can see low voltage region throughout that apical aneurysm region. Now in sinus rhythm, the activation pattern was very interesting and very consistent with an apical aneurysm. So you're seeing 3 different views: earliest activation in the right ventricle coming over the top of the septum into the left ventricle. And you can really see this line of block around this apical aneurysm, this large blue late activation atrial aneurysm. And this is an image that we can see in sinus rhythm. What we're starting to do with our catheter maps in sinus rhythm is to try to understand where that area of latest activation is. And we had some discussion earlier today about the zones of deceleration. We're looking for slow conduction and decelerating conduction. And so we can change the timing into that scar. And what we can see is that the scar is not all activated at the same time. In fact, there's a portion of the scar that's activated considerably later than others. You can see this anterior portion of the scar in dark blue. And in fact, when we look at the directional activation across there, and you follow the arrows, the vectors of directional activation as it sweeps down the lateral wall of the left ventricle, you can see it take the turn into that anterior part of the scar. And you can see what looks like confusion when you have the arrows pointing in different directions. You have discontinuous activation through that period. And again, we're seeing this all in sinus rhythm before we have even started the procedure. And you can see that we have maybe 3/4 of a reentry already in sinus rhythm. When we put the patient through the initial steps of inducing VT, shown on the left is an activation map of the S2 drivetrain that induced VT. It's activation right at that same area of the anterior apical scar. Earliest activation coming out both superiorly and more apically in almost a figure of 8 pattern. When the VT persisted, it looked very similar. Latest activation on that anterior scar, earliest activation top and bottom. When we put catheters into the heart, you could actually map this exact phenomenon. So here is the VT activation with catheters into the heart. Latest activation meeting earliest activation with 2 branch points coming out of that area on the anterior septum near the apical aneurysm. We did the entrainment to prove that indeed that one of those 2 limbs was in the circuit. And what we always love to see is when the ablation comes on, shown here, and the ventricular tachycardia goes away almost immediately. This is the sort of satisfaction that we can achieve in the EP lab by combining all of these modalities together. So we knew where to ablate this patient before entering the body. So on the invasive maps, it correlated beautifully with the non-invasive CardioInsight VT maps, which interestingly corresponded beautifully with the sinus rhythm alterations that we saw even before the procedure. So where does that save me as a user of CardioInsight? Well, it on average saves us about 1 hour per VT circuit. So if you look at how we incorporate ECGI during the procedure, we'll make that detailed scar map with a catheter, but we no longer need to do that because we have that image already. So that's 30 minutes that's saved. And then when the patient has tolerated VT, we would make a detailed activation map with a catheter, but we don't need to do that. We've got 30 minutes saved there All of the other parts, the induction, the looking for the critical isthmus, the testing, all remain the same because you still have to do that with the catheter, and then you still retest for more circuits. But on average, ECGI saves us about 1 hour per VT circuit per patient. And that's real time for patients, and that's real time for users as well.
Phil, talking about time, I'm afraid I need to ask you to wrap up because time is running out.
No problem. So I'm going to finish by showing you what if we don't need the catheters to treat. So what if we can use non-invasive techniques taken from cancer, taken from the basement of most of our hospitals, and get the idea that we can focus radiation into that region of scar. And so this is the concept that Xingwo showed you, where we're able to reduce the VT and almost eliminate VT by focusing radiation into the heart. And by doing it this way, the total procedure time is 10 minutes, not multiple hours, but 10 minutes. And we can harness the images for scar with images from ECGI. And ultimately, after a 10-minute procedure, you see the patient on the left walking out after his non-invasive ablation, and you see the patient on the right who just went through a 6-hour VT ablation procedure, who will spend several days in our intensive care unit. So this is considerably more pleasant and easy for the patient. And the last slide here, and Matthijs, this is the question that you asked me, what are those ECGI parameters that we need to use? Are we looking at unipolar voltage as a representation of scar? Should we be looking for deceleration zones with the isochronal crowding? Should we be looking at the propagation patterns of VT? What are the things that will help us best use ECGI to identify those critical components of the VT circuits? So with that, I would say, as we continue to build and refine and iterate on these systems, please keep the patients and the users in mind. In particular for VT, whether it's with or without catheters, we talked about a number of methods that are important. And at the end, we really want to understand the relationship between the scar architecture and the VT physiology. And it really requires a bidirectional close collaboration between our academic clinicians and our industry with aligned interests. So thank you for your time, and Matthijs, that worked out just perfectly. Thank you.